today we have Dr. Heibert with us. He is a general intensivist and palliative medicine specialist based in Winnipeg with 15 years of experience in both acute, inpatient, and palliative care settings. Dr. Heibert has worked in hospitals and community care, focusing on medical education, early palliative care, and providing palliative services to underserved populations. Dr. Heibert is a good friend of our group, and we are delighted to have him back for his annual talk to us on advanced care planning and everything else you want to ask him.
So as Debbie said, my name's Tim Heibert. I'm a palliative medicine specialist, and I'm also a general internal medicine doctor, which means that I look after people when they come to hospital with a serious illness, whether or not that's a serious illness that's going to get better, or maybe when it's a serious illness that isn't going to get better. So those are the two different jobs that I do. I've been doing talks like this for probably about 10 years now. Hasn't it been, Debbie? It's been 7 for you. And there's a number of different things that we can talk about. So I'm an acute medical doctor. I'm a communications person. I'm a person that helps with advanced care planning and living wills. I'm an acute care provider. So I can talk about lots of different things if you want me to. What are the things that are important for you folks to talk about? Are you interested in talking about advanced care planning and living wills? Yes? Are you interested in hearing about palliative care and how palliative care can help people with lung disease? Yeah. Are there other topics? Those are the two topics that the talk is going to cover. Are there other topics that are of interest to you folks today? So I think I'll go through this talk, and I'm okay if people want to stop me, or we could gather questions and we can do questions at the end. That might be a more kind of efficient way to make sure that everybody gets what they would like to talk about. Yeah.
Dr. Heibert, part of your medicine is treating shortness of breath and pain control. I don't know if part of your talk might touch on that briefly.
Yes, absolutely.
Thank you.
Yes, that's part of it. Okay, so just a little bit about myself. I have no conflicts of interest. No one's paying me to influence my opinion. I'm not in the pocket of Big Pharma. I don't know if any of us are in Canada. I am not a lung specialist, but I look after people with lung diseases almost every day. And I speak to you as a person with palliative care background and also medical background, looking after the bad events that sometimes happen, and as a medical educator. So I hope that that's a useful point of view for you. So I'm going to start by talking about palliative care. Is that a term that people are familiar with and comfortable with, or is it a term that makes people a little bit nervous and worried? Is it a bit of both? Yeah. What do people think of when they hear palliative care? Dying. Bye-bye, see you later. What else do people think about when they hear about when they think about palliative care? Comfort. Special care. Access to special care. Yeah, that's a good point. I'll offer you what the term palliative care is meant to mean, and I want to reassure those of you who think it means giving up on things that it actually doesn't. So this is the World Health Organization definition. It's too wordy. So I've bolded the things that are the most important. So palliative care is not a place, although there are places that give palliative care. And palliative care has specialists, but any doctor providing care can provide palliative care. Palliative care is about making the best of the life you have, making the best quality of life possible for that person, supporting that person in a way that's important to them, and supporting that person's family and loved ones in a way that allows them to live well while they're living. So we give palliative care supports to people who have bad illnesses, but palliative care isn't about dying. Palliative care is about living well. That's what it's supposed to be for. So we do that by paying really good attention to people. We do that by keeping track of their illness and providing the appropriate treatments for their illness in whatever way is possible for that person and is appropriate for that person's wishes. We pay attention to pain. We pay attention to shortness of breath. We pay attention to fatigue, sleep problems, anxiety, nausea, constipation. We try to pay attention to everything that affects quality of life so that a person can live as well as they can. Can a doctor do that all by themselves for a person? No. Doctors don't even know how to do all of that. Some of those things are best done by a nurse. Some of them are best done by a physiotherapist or a respiratory therapist, an occupational therapist, a counselor. So good palliative care requires care from a team. And good palliative care means supporting a person and also supporting their circle of loved ones and community around them. And so then that's what we strive for. Are we perfect? No. Are there access issues? Sometimes yes. And let's talk about that when we get to that point a little bit later. But this is what we're meaning. When we talk about palliative care, it's care of the whole person. It supports families. We recognize that it's more than just addressing pain or shortness of breath, that it means addressing a person's social circumstances, whether they have enough money to pay for their medications, whether or not they're doing well in their relationships in their family, whether or not their emotions are well supported, and their spiritual needs as well. So it means thinking about all of those things. It also shouldn't be done abruptly. Have any of you seen this before? If you've seen me speak before, you've seen it before. This is meant to be a blue triangle, and this is meant to be a pink triangle with a diamond in the middle. This blue triangle represents treatments to try to control a disease or cure that disease. So OFEV, treatment of a pneumonia, going to the intensive care unit if you're very sick with respiratory exacerbation. All of that is part of trying to either fix or control your illness. And those treatments are important, aren't they? And they should be offered to a person for as long as they can help that person, shouldn't they? For as long as they can help that person, they should be offered to that person. And then it should be up to that person and their family what portions of that treatment they want or don't want, right? You guys should be in the driver's seat. You guys should be the bosses for your own care. While we're trying to fix your illness, do you think we should care about whether or not you're suffering? I think so. I think that's why I became a doctor. Sincerely, I think that the reason why we become doctors and nurses and other types of healthcare providers is that we want to actually help people. And so only doing the things that keep a person alive and ignoring the things that a person that causes a person to suffer would not be great. This other triangle is meant to represent the care that we can provide to help with quality of life, to reduce suffering, to improve a person's life while they're living. These treatments may be part of treatment of the illness, which is why there's this overlapping diamond, or they may be treatments that simply make a person feel better and don't change their illness. As time moves on with an illness, sometimes people get better from a particular illness. Some people with lung disease will receive a transplant and then they have a whole new journey after that. And other people, their disease progresses, fixing their illness isn't possible, and they get weaker and they have more need for comfort supports. And so then this diagram is meant to reflect that both of those things might happen. But we have lots of ways to provide this, and we shouldn't only be focused on curing an illness or controlling an illness. We should also be focusing on quality of life at the same time. And I hope for all of you that are facing a lung disease that you are getting both of those things at the same time, whether anybody's calling it palliative care or not. I don't care whether someone calls it palliative care, just that you're getting it. It should mean addressing shortness of breath, if it's affecting your quality of life, stopping you from doing things. It should mean managing pain. It should mean managing anxiety. It should mean managing constipation if you have that problem, and a lot of us do without talking about it, and it causes us to suffer. It could mean having other problems in our bodies that affect us, that stop us from doing the things that we want, or it might be an emotional need or a social need. All of those things deserve to be addressed so that we can live well. Does that make sense to everyone? Is that a less scary definition of palliative care? One of the things that's important to know is that when we offer palliative care treatments to people, their life expectancy does not change. There are a couple of studies that show that people might even live longer after palliative care is added. Those are for particular types of cancer. I don't want to make too much out of that, but the big point is that when we start offering these things to help people feel more comfortable and feel better, we're not compromising their ability to live. Okay, we're not taking away their chance at living. Okay, we're trying to support it. So palliative care is not giving up on your treatments. Palliative care is not a failure. It doesn't mean that your doctor should walk away from you. It should not mean that. Although I can't speak for what other doctors do, but it should not mean that. Palliative care does not hasten death. This slide is older. Palliative care is not medical aid in dying. We do not cause people to die when we provide palliative care. If a person wishes to have medical aid in dying, there's a lot of things to talk about. Palliative care usually is trying to support that person, but that's a separate decision, a separate thing from palliative care. And it's not only for the last few days of life, which is what is often thought, even by doctors and nurses sometimes, that palliative care is only for when everything has failed and the person's going to die in the next few days. That's when we start palliative care. That's much too late. We can help people live better much sooner than that. And it's not a place, although there are places that provide palliative care. Any questions about that right now? Does that make sense a bit? Okay, and we'll talk a little bit about the specifics in Winnipeg as we go forward. So here's a slide. This is too small. I'll read some of it. It's too small for me. So myth number one is that palliative care hastens death. We just talked about that. It does not. When we do a good job of addressing symptoms, people live better. Okay, they don't live shorter. Palliative care is only for people with cancer. That's absolutely not true, and it's an unfair myth because it causes unfair distribution of resources, which gets to the access question. It is not only for people who have cancer. People who receive palliative care stop eating and die of cancer, stop eating and die of starvation. It is true that with many different illnesses, whether those are cancer or a heart illness or a lung illness or a kidney illness or a liver illness, people will lose their appetites, will lose their desire to eat, and then eventually lose their desire to drink fluids too. That is not going to lead to starvation. That's simply something that happens as a person's body is failing. And people don't suffer from that. So it's a myth that people starve to death because they're not eating. Palliative care is only provided in a hospital. That would suck. What's your quality of life like when you're in the hospital? We do have places in the hospital where we do provide palliative care to people who are stuck in the hospital, and we do have places that are dedicated to providing palliative care at St. Boniface Hospital and at the Riverview Health Center. Those are places where for people who need palliative care, specialized palliative care, and who are not well enough or can't be cared for at home. But as much as possible, we try to support people in their own homes or wherever they are. Sometimes that might be in a chronic care facility or a long-term care facility. Sometimes that might be in supportive housing for someone who has dementia. Sometimes it's in a personal care home for people who have frailty and dementia. But we do it wherever a person is as much as possible. We need to protect children from dying. Well, when we shield our children too much, then they're not prepared to deal with these things as they get older, and that isn't helpful to them. Pain is a part of dying. Just no, that's just not true, and it shouldn't be true. Not today. Not today. Do people have illnesses that cause pain? Yes. Does dying itself hurt? No. Taking pain medication in palliative care leads to addiction.
Do we care?
Not that much. I'll give you a frank answer to that question. For most people who have an illness that requires opioids like morphine or something like that, the chances that the person will have an addiction are low. The main risk would be someone who's already been suffering from addiction, and then it's hard to provide them care with also harming them at the same time. When a person is dying, if they have pain or if they're short of breath, am I going to withhold morphine because they used to be addicted to morphine? Do you think I would? No. I'm going to provide them with what they need to prevent them from suffering or to control their discomforts. If somebody is living for a very long time with an illness, 10 years or longer, 15 years, and we very generously prescribe morphine or hydromorphone to that person, we're putting that person at risk, and then that medicine might not work for them very well over the very long term. But if you need these medications because you're suffering, we're going to give them. The chance of addiction is low and really only exists for the people who've already had addiction. And then we work with that person and support them in multiple ways, if as much as we can. Morphine hastens death. Morphine does not hasten death when it's prescribed by someone who knows what they're doing. There is such a thing as an overdose. That's a medical error when that happens. It's quite rare. It doesn't happen very often that a doctor would cause somebody to die because of morphine. And it's kind of hard to do. You'd have to give someone a lot more than people would think. So no. What is this one? Palliative care. Something my doctor. I can't read that one. I've let my family members down. I've let my loved one down because he or she didn't die at home. That's maybe for the caregivers here. A lot of people can stay home at end of life if that's what they want and if they have a really robust family support. But not every family has enough resources for that to be possible. And to be perfectly honest, not everybody wants to stay at home at end of life. When they do surveys and ask people, 70% of people will say that they want to be at home when they're dying. But what they really mean is that they want to be at home when they're dying as long as they can do stuff and enjoy being at home. When I've been doing this work for 16 years, and what I've noticed is that lots and lots of people, when they need a lot of help, they don't want their family necessarily to be the ones doing all of it for them. And a lot of people do want to be in hospital. And so it's really hard for a family to provide that care all the way until the end of life in a home. It's not always doable because of how much care a person may or may not need. And it prevents families from being families. It turns families into mini hospital ward staff. And so, no, it's not a failure if a loved one has to come in. Who needs palliative care? If you have an illness that's not going to be cured, your doctor and your care team need to be considering your quality of life. So if you have an illness that's not going to go away, we don't need to call it palliative care if we don't want to, but your quality of life must be considered in all the treatments that you get. Is that a fair answer?
Yes.
Yeah. And so a palliative care approach doesn't need to mean that you're labeled as a palliative care patient. In fact, I don't like labels. You guys probably don't like to be labeled either. Is that fair? I'm just making a guess. You guys probably don't want to be labeled. You guys don't want to be put in a box or a category. No patient I've ever met wanted that. Palliative care for lung diseases there's some fairly specific considerations, and now we're going to get to what someone was asking me before. So we're focused on quality of life, which is the center gear here. And then we also want to think about dyspnea, that's shortness of breath in medical jargon. We care about cough, we care about fatigue, we care about anxiety, we care about mood, depression, we care about weakness that impairs your ability to do what you want to do. And we care about more stuff than this, but these are the most common things. These are the most common things. So we care about all of these things, and we want to try and do something about all of these things. So a whole bunch of issues requires a whole bunch of different strategies. And some of this is formally considered palliative care, and some of it is just part of good care for having interstitial lung disease. So pulmonary rehab. Are some of you doing pulmonary rehab? Yeah? Does it help with your quality of life? Does it help you maintain? Does it help you maintain yourself? I hope it does. Some of you are wearing supplemental oxygen. That helps you live longer, also helps you live better. So that's in that diamond that we were talking about before. Symptom relief, and we'll talk a little bit about that. Treatments to try and help you live longer, to help your lungs work better. Whether you have bronchiectasis or pulmonary hypertension or interstitial lung disease, we have treatments that are intended to try and help your lungs actually work better. End-of-life care for when that time comes. Psychological and social support, that ought to be all the time. Involvement and support of your friends and family, that ought to be all the time. Timely and confident diagnosis, making sure that when you first become ill, that you get the things that you're supposed to get and that things get sorted out properly. Awareness of what's available, having an ILD specialist or a respirologist who's very familiar with treating ILD. And I hope you all have that. I hope you all have that. I've had the pleasure of working with Dr. Lawrence. Debbie, I think it's been since 2014 that that's when I got to know Dr. Homick. And I don't know if he calls himself an ILD specialist, but he's certainly quite good at providing the care. Yeah. And there's others. There's Dr. Colburn that some of you might know as well. So here's all the things. So there's aggressive stuff, and then there are things that make you live better, feel better, and also help with your illness. Some people will wear BiPAP. Some people will use oxygen when they have an exacerbation, even high flow oxygen. Pulmonary rehab, puffers, immunosuppressants, OFEV, oxygen, opioids, all of these things help you live better and possibly help you live longer. And then all of these other things provide support. There are studies that show that when we do this well, adding palliative care into respiratory care improves shortness of breath, doesn't change your lab tests, okay? Improves quality of life, and sometimes helps people live longer. But the more important thing is that asking for palliative care won't shorten your life. That's the important thing. So I'm sure that some of you could add more, but shortness of breath, cough, fatigue, weight loss, inability to exercise or be active, and then pain for various reasons. Those are big things with IBF, aren't they? So what do we do? Shortness of breath feels different for different people. Are there people here who experience shortness of breath? Yeah. Are you getting things that help you? So some people just plain feel like they're hungry for more air. They feel like their breathing just isn't big enough. Some people feel the work of breathing and it feels like hard work because it is hard work. If you have ILD, you have stiff lungs, and it literally is hard work to breathe. Some people feel chest tightness. Some people have rapid breathing and it feels uncomfortable to them. There's lots of different ways that shortness of breath can feel and be experienced by different people. We want to help people. I know some people feel like they feel like they're in trouble. It's frightening. feel like they're drowning, it can trigger anxiety. So we really need to help people with that distressing feeling. There's non-drug things. I hope you know some of this already on your own. Being upright helps in most situations rather than laying flat. Being in a nice bright place, lower temperatures, if your body can tolerate lower temperatures, having air moving helps, doesn't it? Even if that air doesn't have extra oxygen in it. Pulmonary rehab in research studies has shown benefit in how far people can walk, how much they can do, and it's also shown some benefit in terms of shortness of breath scores in different studies. I think that your mileage may differ. Everybody's going to be a little bit different, but if rehab is possible, it can help prevent some of the suffering down the road. Good nutrition. Is this being emphasized when you go to clinic, etc.? Nutrition can help for those of you who are able to do it. Chest wall vibration is not something that we have in Manitoba, to my knowledge, Debbie. We don't have it.
What is that, please?
I don't understand it very well. It's literally a machine that rapidly pummels your back. Yeah.
I got one.
Yeah. And
Driving in Winnipeg streets, I don't know.
yeah, maybe we just need to drive on Archibald or something. This is another thing that we don't really have. It's similar to TENS that sometimes people can have inserted, but I don't think we don't have ready access to this. And then sometimes people will see a psychologist who will teach them certain mindfulness techniques that can help with coping with shortness of breath. Those things can't take the shortness of breath away, but they can help people manage it better. And so sometimes seeing a psychologist that has specific knowledge about respiratory disease could be helpful. I don't know how many people like that we have here in Winnipeg. Are you able to hear me okay? Yeah. If your oxygen level is low, we should fix it. People with pulmonary hypertension and ILD in particular will feel better if their oxygen level is above 90. Are any of you keeping track of your oxygen level? Do you notice when your oxygen levels fall? Yeah. So I have learned from observing my patients that they feel better when their oxygen level is above 90 with ILD. So we should be doing everything that we can do to help you get your oxygen level above 90 and keep it there. Does that also help you live longer? You betcha. Yeah, that helps you live longer too. So as much as we can, we should be helping your oxygen level stay up. And so then that's a treatment for your illness, but it's also a palliative treatment. Okay, so then that fits right there in the middle. Sometimes people feel short of breath with a normal oxygen level. More oxygen won't help that much. If you're already wearing oxygen and your saturation is 92 or 93 or 94%, but you feel short of breath, that's real. We need to help you, but turning up the oxygen might not be the thing that does it for you. It may not work. You can try, I don't care. Oxygen's not that expensive in terms of turning the dial. If you have a concentrator, your concentrator is going to go what, to 4, 4.5? Some of them will go to 5. Most of them won't go to 5. Some of them will, because the alarm will start going off. And for some people, you might have a 10-liter concentrator. Some people might have 2 concentrators put together so they can go to 12, that sort of thing. If that helps you get to the oxygen level you need, that's great. But some people will still feel short of breath with a 90 or a 92 or a 93% level. So then oxygen won't fix it all, right? What do? This is where people get nervous, because now we're going to start talking about morphine and hydromorphone. Do any of you know where these medications came from in the first place? So have you heard of opium? Where does opium come from? Poppies. So communities, indigenous cultures, people from all over the world have known about the benefits of poppies for a pretty long time, right? What do these medications do? They imitate something that's naturally in our body. Do any of you have children or family, or maybe in your earlier life you ran marathons or triathlons or did long distance running? For those of you who did that, how did you feel after doing a long distance exercise? How did you feel? You felt good. Do you know why? Endorphins. Endorphins are drugs that your body makes. Endorphins are drugs that your body gives you during heavy exercise, during sex, and if you're running away from a bear or a tiger or a lion. So endorphins are something that your body uses to help you feel better under certain circumstances, or to help you survive something painful so that you can keep running or keep fighting. You've all heard of fight or flight, right? You know, there's been a car crash, you know, you're in the middle of a disaster area and you have to get out, but you've fallen and you broke your ankle. What does a person who's fallen and broken their ankle do if a bear is chasing them? They get up and they keep running. It's what they do. And the reason that they can is that their brain is releasing endorphins into their body so that they don't feel their pain. So morphine, hydromorphone, oxycodone, fentanyl, all of these kinds of medications were imitating the natural endorphins of your body to give you that relief. If somebody was on those things for 10 years, yes, they can become addicted. In the short term, or with serious illnesses where we need that relief, it actually makes your body work better. It actually makes you better. It doesn't matter what kind of shortness of breath you have, these kinds of medications will reduce the shortness of breath feeling. They do not shorten life expectancy so long as your doctor knows what they're doing. There is such a thing as overdose, but we need to be very careful. So when we start using these kinds of medications for people who have lung disease, we start at quite small doses, give them only a few times a day at the beginning because they're short-acting medicines, and then we adjust them little by little by little. I won't expect a show of hands here, but I expect that some of you are on morphine or oxycodone or hydromorphone to your benefit. Maybe some of you are wearing a fentanyl patch, which is helping you through the day. These things can definitely help people with lung disease, but we do have to be careful. All of the major societies recommend that they be used. The Canadian Thoracic Society, which is the Society of Respiratory Specialists here in Canada, the American College of Chest Physicians, and the American Thoracic Society, which are all the American doctors who treat lung disease. All of these societies recommend that we use morphine and its relatives with care and with expertise in lung disease. Right now, the Canadian Thoracic Society is working on a new guideline for how to do this, to update doctors in Canada on how to do this type of care. I've been invited to participate in that. I'm honored to be part of that work. Opioids are safe in safe hands. I do have to say that if your doctor does not know how to prescribe, that's not a good thing. But as long as your doctor has been properly trained, these medications can be used safely. Experience, sometimes they need to get some input from a specialist. I do get calls from different doctors to ask for help. And then you know that it's going to be done carefully because the person is intending to be careful. Yeah. Would it be helpful for you guys to know what too much opioid looks like? To be able to recognize that? So when someone starts taking morphine or one of its relatives, at the beginning, people do tend to be a little bit tired compared to their normal self for 2 or 3 days, let's say, and someone might be even a little bit more sleepy, a little bit for a few days. And that will settle usually after 2 or 3 days. Everybody becomes constipated when they start taking these medications, almost everybody has to take laxatives to keep themselves going, literally. So that's normal. When we give too much, people can get really sleepy. Their pupils get really small. People will have trouble concentrating, remembering, might get confused. And if it's really, really too much, a person's blood pressure might start to drop and their breathing will slow down. So when we give morphine or its relatives for lung disease, we do not intend for the person's breathing to slow down. A person has to breathe however they have to breathe. So if you normally breathe at 24 per minute, if you start on morphine, your breathing should still stay about the same in terms of how much you breathe per minute. Okay? I don't know if any of you keep track of how fast you breathe, but just as an example. If somebody's blood pressure is falling, if they can't stay awake, if you look at them and their pupils look teeny tiny, then that person's probably had too much. What can you do about it if that's happened? If you can still wake the person up, and if they can still respond to you, and if they're still breathing, you don't have to do anything, just not give them anymore for a while, and then talk to their doctor about reducing their dose. How long does it take for these medications to wear off? It would take 4 to 6 hours for a dose of morphine or hydromorphone to wear off. So if a person is sleepy from what seems to be too much, if you just don't give them their next dose, in a few hours, they're going to be more awake. If the person's not waking up, then you need to call for help. Okay? If a doctor is prescribing, it is very rare for someone to go into respiratory failure from an opioid. It does not happen very often, which is why I say that opioids are safe in safe hands. When they're given, because they're part of that fight or flight response that our body uses when we're fighting for our lives or trying to survive something stressful, opioids reduce stress hormones and stress levels in the body. So when you're short of breath, many of you know that you feel tense. Many of you will feel maybe some anxiety or just not at ease because your breathing is hard. That if you give the right amount, you might not feel terribly different, but you'll find that those things are all coming down because when you take hydromorphone or morphine, your stress hormones will go down. Does that sort of make sense to you a little bit? Yeah. It's important to know that your oxygen levels stay the same, your carbon dioxide levels stay the same, your breathing stays the same. And if your breathing is slowing down because of your morphine, that's a little bit too much. Okay? We start low and we titrate carefully. Is this a problem? Is anxiety a problem? When we treat shortness of breath, this can get better, but treating shortness of breath shortness of breath itself isn't the only reason why people might feel anxious, is it? We think about our families. We think about our loved ones. We think about the future. We think about today. We think about tomorrow. All of these things are stressful. And so what we hope is that in addition to helping with breathing, we make sure that people have the supports that they need. And they ought to also have someone to talk to if they need that, counseling if they need that, and just to know that they have a network of support. So people deserve to have that. Is this a problem? The reason why you're coughing matters, and so then seeing a physician or a nurse practitioner or a specialist of some sort to sort out why you're coughing is very important, because there are different treatments for different types of cough or different reasons for coughing. Sometimes coughing is associated with acid reflux and heartburn, which then would mean that you need to stop drinking coffee, which I don't know whether I could do that, but and take an antacid medication to control that. Sometimes it means that you're aspirating and you're not swallowing very well and you need to modify the way you eat and drink. Sometimes the cough is because of your lung disease. And so then different reasons require different treatments. Sometimes people need medications to suppress the production of saliva. Sometimes people need other types of treatments, something to stop them from having postnasal drip. If the cause of the cough can't be taken away, what can we do? There's non-drug treatments. At my house, the non-drug treatment is cinnamon and sugar and honey and lemon, and like hot tea with lemon and syrup, or not syrup, or honey, with honey and cinnamon. So non-medicated things can be very soothing. Lozenges can be soothing. Something with eucalyptus or menthol can be soothing. But that's not always enough, is it? That's not always enough. Gabapentin is a medication that can help with cough. We need to watch the doses because the main side effect of this medication is sleepiness, and not everybody tolerates that very well. But gabapentin, and then another related medication called pregabalin, that one's called Lyrica. Those two medications can sometimes help with cough. Steroids sometimes help with cough if it's part of your ILD. Okay. And if nothing else is working, opioids, morphine, codeine, hydromorphone, hydrocodone, and people often like to take that as a syrup. The doses would be small because we don't want people to get sleepy with that. So there's a few different things that we can do. Just because it's a lung disease doesn't mean that people don't hurt. But we want to be very careful with how we manage pain in lung disease. And that's because if we overdo it with opioids, we can put people into trouble. And that's what I was talking about in terms of safe prescribing. So the treatment for pain should always be focused on what the reason is for the pain. Okay. And most of the time, if someone has a lung disease, we would want to use something that's not morphine for their pain, so that morphine gets used for their shortness of breath. Does that make some sort of sense? Morphine is for your breathing. Okay. And we would only want to use morphine for your pain if nothing else would work, because we want to keep the morphine for your breathing so that it keeps working for you. So there's lots of things. We use Tylenol. TCA stands for certain types of antidepressants. The most common ones would be amitriptyline or nortriptyline, for those of you who like specifics. Gabapentin again. Have you heard of this medication? Yeah, some of you have. It's a medication that's been historically used for chronic pain in a variety of areas. It can be useful. Its main problem is it can make people sleepy as they get used to it. And so then sometimes that sleepiness limits its use. Pregabalin is Lyrica, which is the primary treatment for fibromyalgia. Okay. SNRIs are another type of antidepressant that can help with pain. And then anti-inflammatories would be ibuprofen or indomethacin, naproxen, Celebrex. Okay. So we like to use these non-opioid, non-morphine medications as much as we can for the pain, using heat, using cold, using massage, acupuncture. All of these things can help for certain people. And I would encourage people to consider non-drug treatments. Cannabinoids can be used for pain in lung disease. If you can go to a doctor who prescribes and ask for cannabinoids. And if you were to do something else, you want to avoid THC. Okay, are you at all familiar? There's two main ingredients in anything that comes from a cannabis plant. There's THC, and then there are other cannabinoids, cannabidiols. And those are the ones that can help with pain. I hope it doesn't need to be said that you shouldn't smoke this stuff. Fair enough?
Shouldn't inhale anything.
Shouldn't inhale, well, only air.
That's right.
Only air. Only clean air. Only clean air. So never smoke anything. It's the price that you would pay with your lungs is too high. But cannabinoids, mostly cannabidiol, CBD oil, can be beneficial for pain. I can talk a little bit about the palliative care program as it exists in Winnipeg. Maybe I'll stop there and ask, what questions do they have? What questions do folks have about palliative care here? I heard one thing at the beginning about access, and that is an issue. Are there other questions about what palliative care as a program can offer? Like, do you have any specific questions or concerns? Has anyone had any experiences?
If you have palliative care come to your home, you have to pay for it?
Palliative care can come to your home. You do not have to pay for it. Yeah, you've already paid for it. You pay taxes. Yeah.
I'm curious, at what point does a person qualify?
That's a good question. I will do my best to answer it. It's a little bit complicated. Yeah.
Can you repeat the question?
The question was, at what point does someone qualify for palliative care? We're in a difficult time in healthcare, and it affects all parts of healthcare in that we don't have enough healthcare for everyone who needs everything. Is anyone surprised by that? No, but I will apologize because it's not right. People deserve to get palliative care if they're suffering from their illness. And I wish I could say that we have the resources to universally provide that, or that we have the attitude and that all doctors know how. But those things aren't quite true. Not all doctors know how to provide palliative care, and we don't have quite enough of the people who do know how for it to reach everyone. But everyone does deserve it. Earlier in an illness, palliative care strategies, palliative care treatments should be offered by family doctors and should be offered by lung specialists, etc. They should be including palliative care treatments along with the OFEV, along with the steroids, along with the oxygen, along with the suppressive antibiotics. They should be providing palliative care strategies, palliative care tricks to help you. When a person is reaching the point where their quality of life is being more and more impaired, when a person can do less and less because of their illness, when their suffering is starting to increase, if they're coming in and out of hospital, that's probably around the time when a person should get some palliative care help from specialty palliative care. We have lots of challenges in Canada and in Manitoba around providing palliative care because the systems of palliative care were designed for people who have cancer. And that wasn't right, but that's how it was done. And so it's designed around the way that cancers progress. And cancers, when they're not cured, progress in a very predictable way. So we expect people to be predictable. Is ILD predictable? No. Is COPD predictable? No. Is heart disease predictable? No. So the way that palliative care structures were designed unintentionally makes it harder to sort out palliative care for people who have something that's not cancer. We're trying to change that. We're trying to change our focus not on knowing exactly how much time a person has to live and changing it to when does the person need the help? When do they need the help? And so it's not perfect, but that's what we're trying to do. So when does a person need to see someone from palliative care? I'll say that as a separate question from enrollment in the palliative care program. But when does someone need to start seeing someone who's a specialist in palliative care? That would be if they're suffering in a way that their own team isn't able to help. If you're not able to get the help that you need in terms of your suffering from the team that's looking after you, then maybe the palliative care team could help you in a consultation. And if you need more, and if things are starting to change, then maybe that's time to be enrolled in the palliative care program. The official rule, which is, again, things are in process of possibly changing, is that enrollment in the palliative care program is intended for people who are in their last 6 months or so of living. I am personally an advocate for changing that. And I'm being recorded, so I have to be diplomatic. My opinion is that this should be dictated by what people need, not by how long they need it for. We're working on it. But the official policy is that when someone's around the last 6 months of life is when official enrollment is to happen. But we're trying to become more flexible, and we're trying to focus more on people needing the help rather than how much time they have left to live. I know that's not a perfectly satisfactory answer. That's the best that I know. That's the best I can say. Is that fair?
It's contradictory to the earlier statement.
I know.
Yeah.
I know. The approach of palliative care should be offered as soon as someone
Right.
is known to have an illness that can't get better. But the approach of palliative care does not require a palliative care specialist.
Understood.
That can be provided by a family doctor. We train every family doctor that trains in Manitoba spends a month with us getting taught about palliative care. I can't say that about all the specialists. I wish I could. But every family doctor that trains in Manitoba gets a month of training in palliative medicine, and we expect them to provide this for you folks at a primary level. And then when a person's needs are too high or when their needs are too complicated for a family doctor, that is when consultation to palliative care should happen. And that consultation should be available. Unfortunately, our resources haven't quite met that statement, but I think it's fair for you to expect that and to ask for it. So there can be consultation with a palliative care doctor or a palliative care nurse specialist, and that can help a person. And then if need be, then palliative care enrollment, meaning they get all of the supports of the palliative care team, could happen a little bit later. But having palliative care work along with your main providers, that should be available quite a bit earlier. But we're working on it because we don't have the resources that we should have. Yeah, our mouth needs to match what we do. We're working on it.
Yeah.
Yeah, you're not wrong. Yeah.
Is palliative care available outside of Winnipeg? And then if not, if you live outside of Winnipeg, can you come into Winnipeg for it?
Yes and yes.
Dr. Heibert?
Yes.
Because you're getting recorded, can you please repeat the question?
Is palliative care available both inside and outside of Winnipeg? And if you need the supports that exist in Winnipeg, can you come in for them? The answer to both of those questions is yes, and I'll explain. Every region of the province has been mandated by Manitoba Health to provide palliative care. Every region of the province has a palliative care program. Most of the palliative care, so every region has a palliative care program. Most of the specialists in palliative care are either in Winnipeg or in the Southern Health region. So specialty palliative care is mostly available within Southern Health or Winnipeg. If a person is outside of those regions and needs that, absolutely they can come into the city, especially if they need hospital palliative care, and receive that care in Winnipeg. Have I answered your question? Every region. We don't yet have palliative care specialists in every part of the province. The Interlake has one, so that's a start, and might be getting a second one soon. The Far North does not have palliative care specialists on There are some doctors who do palliative care that go there sometimes, but the North does not have palliative care specialists staying in the North. Southern Manitoba does. Boundary Trails and out of Boundary Trails and out of, that's Winkler Morden. And then Steinbach, they're palliative care specialists at both of those hospitals. And they have cars and they go to people. Okay. And in Winnipeg, we also have cars and we go to people if that's what they need. The specialized if somebody needs specialized palliative care in the hospital, that's either St. Boniface Hospital, where we have a palliative care unit, or Riverview Health Center, where we have a palliative care unit. And yes, people from other parts of the province sometimes need that, and they're brought to us. So let me tell you a little bit about the palliative care program then, because we've been talking about it. So this is a team that exists here in the city. There are, I think, 18 doctors that work various percentages. And then we have specialty nurses, and we have nurses that go and visit people in the home. And we have coordinators, people who function like home care coordinators, but do much more than home care coordinators do, who can help people be a point of contact, someone that you can call if you need help. Earlier in an illness, before someone needs an awful lot of help, but maybe needs some expert advice, they can receive consultation from a palliative care doctor. I, from time to time, will meet people who are on the transplant lists, who are suffering while they're waiting. And so I'll work with Dr. Porhanek or with Dr. Gruchalski or whoever it might be to try and help them as we're working towards the transplant, just as an example of what kind of consultation might happen. For those people who are still doing lots and are not having a lot of trouble, but are having a bit of shortness of breath, I sometimes get asked to see them to help with their shortness of breath. So that kind of consultation is available. That might be a few visits, but it's usually going to be working together with your respirologist. If somebody's care is more complicated, then we might work together to try to help a person. Enrollment in the palliative care program helps when a person's disease is progressing and we can tell that their needs are going up. And the rule, which I think is changing, what the rule is the last 6 months of life, but my opinion is that we need to be less stuck on that number and more focused on what people need. When someone's enrolled in the palliative care program, several things happen. They get a coordinator who is their quarterback, helps them sort out things that they need, supplies, equipment, a bed, your oxygen, all of that, arranging for nurses to visit you in the home, contacting your doctor to make sure that everybody's on the same page for care, being the person that you can call. Helps make sure that you have your medicine. If you need to be visited by a nurse, they'll arrange that. If you need help from a healthcare aide with home care, they'll help arrange that. If you need a doctor to come see you, they'll call somebody like me, get in my car, come visit you. 24-hour helpline. If someone's having trouble on the weekends, someone's having trouble at nighttime, you have someone to call. You don't have to call 911. You can call us. Okay? And we try. We're not perfect. We don't have everything, but we try. We pay for meds. We don't pay for OFEV, but we pay for pretty much everything else. Yeah. Debbie, that's kind of what it's been. And people decide for themselves, whether or not they've been benefiting from OFEV at that time. But a lot of people continue with the OFEV. And other people are saying, I'm sick of having a sore stomach, and then they stop. Yeah. And for people who really need it, if the nurse is visiting and help from healthcare aides and the medications and the other supports are not enough, or if the person's getting weak and it's too hard to be at home, we have places to bring them to. St. Boniface Hospital has a ward for people who have complex care needs, and people with ILD do on occasion end up receiving care there. And more frequently, people with ILD end up at Riverview, which is a good place of care for them. Debbie, I'm sure you've had the experience of people going to Riverview. It's a very good location of care for them. We even have an Optiflow that the foundation bought us for those people. Yep, so we have an Optiflow there. Do you guys know what Optiflow is? So Optiflow is a special machine that can give up to 50 liters of oxygen. And so you remember what I said before about low oxygen. Is low oxygen okay? No. So on the palliative care ward, we have a machine that's normally thought of as life support. We don't think of it as life support. We think of it as symptom management. So for some people, we use Optiflow to help them because that's the only way to get their oxygen up so that they're not suffering with their breathing. So the palliative care wards are there for the people who need them, either during a rough patch or because they're getting weaker with their illness and it's too much to be at home, or their symptoms are hard to manage, and they need to be under the care of a doctor who's going to see them every day, and nurses that are going to check on you over and over again. So we have those two places, but we only have 45 beds. But we do the best we can with those 45 beds. We also have a hospice that's beside the Grace Hospital. It's not in the hospital, it's beside it. And that's for 12 people who might not have very complicated needs, but it's too hard to be at home. They can't be at home. And they're in their last few months of living and they just need to be cared for in a good way. And so then that's what the hospice is for. Our calculations are that Winnipeg should have 75 hospice spaces. We have 12. Manitoba should have 150 hospice spaces. Manitoba has 12. So maybe that will change. I know that we've had some change in government leadership, but that's a big discordance, isn't it? Have I given you a little bit of an explanation of the palliative care program? We can do good things for people, but we aren't as big, or we're still working on being better, but we can do good things for people. I saw a hand go up.
I just wanted to say, it's an excellent presentation. Thank you.
You're welcome. I'm not done. The reason that I'm not done, and I'm sorry, it's 2:00. Please have some patience with me. We need to talk about this.
You have lots of time. You
Okay.
have another hour.
Okay. We need to talk about advanced care planning. Are you familiar with this term? Are you familiar with living wills? How many of you have one of these? Okay, you all need one. Okay, whether you're one of the people with ILD or not. If you have medications, if you have any medical illnesses, you need to have one of these on your fridge. Okay? Are you familiar with advanced? Yeah.
How legal are those? Like, are those notarized by a lawyer?
No, you just do it yourself and you get it signed by a witness. And Debbie has some back there. And no, it doesn't matter whether it's your spouse. No. The advanced care form that's in the ERIC kit is the only advanced care form that a paramedic will follow. They will not follow your living will. I'm going to say that again. They will not follow your living will. They will follow the document in your ERIC kit. Are they breaking the law? I don't know. But the paramedics in Winnipeg have to follow the rules that they've been given. And the rules that they've been given are that they will attempt to resuscitate any person unless this form is filled out. And those are the rules that the paramedics have to follow. Okay, so that's why I want everyone who has any kind of significant illness should go through this process of advanced care planning. It doesn't really matter to me what you decide to put on here as long as what you put on here makes sense for you. I'm not going to tell you what your answers to the questions need to be, although we'll talk about it. Advanced care planning is a type of living will. It is going through the process of thinking about your health, thinking about your medical conditions, thinking about what might happen in the future, and what kind of care you would want if those things were to happen. How do we make those kinds of decisions? We think about what's important to us in our lives, and we think about what we would be willing to go through and what we would be willing to not go through in terms of treatments that might cause us to suffer. And we think about if we were to survive something, what would our life be like after? And is that going to be okay for us, or is that not okay? I'm 55 years old. I have a 7-year-old daughter. I have a 17-year-old kid. I have a 21-year-old kid. I'm married. I have lots of nieces and nephews. I was at the soccer field yesterday watching my kid play. If I drop dead here today, what do I want you guys to do? Resuscitate me. Find the AED machine. Do everything you can to me. 35 years from now, I'll be 90. Am I going to have the same answer 35 years from now? Probably not. I can't speak for my 90-year-old self if I ever get there, but my 90-year-old self will have something else to say. And it depends on your life circumstances. It depends on what's important to you. So what I want you to do is think about your life. Think about the things that are important to you in your life. People will think about their family relationships, their loved ones, the things that they do in their lives that give them meaning. Gardening, golfing, traveling, whatever is possible, not possible. As our lives change, that list gets shorter. And so then we need to think about what are the things that are really important to us. For some people, those things are physical things, and for some people, those things are intellectual things or relationship things. So think about those things that are really important in your life, the things that you can, if you lose them, you're still willing to live, but the things that if you do lose them, that would be too much. And what are the priorities? Are you willing to suffer from treatments that cause suffering, such as being in the intensive care unit or in the hospital getting poked and prodded? Or are you not willing to have those sorts of treatments anymore? Learn about your illness, not just about what illness that you have, but learn about what the treatments are that you can get that might still work for you and what they could do for you. I would hope that you all have access to care providers that will have that kind of conversation and that they would give you that information. I hope that for all of you, that your doctors and nurses can all give you that kind of information. Decide. It's very important to have either one person or a small group of people who help you make decisions, or a small group of people who can be your substitute or the person who speaks for you if you are too sick to speak for yourself. Often that would be someone's, husband or wife. It might be their sister or brother. It might be one of their children. It could be their best friend. Sometimes it's a neighbor. It doesn't matter who it is, as long as it's a person that is close to you and a person whom you've had these kinds of conversations with and that they understand what your wishes are. So who is the person that speaks for you when you cannot speak for yourself? And that can be anyone that you want it to be. And it can be more than one person, but don't make it that they all have to do it together. Because that gets too hard. Yeah. Talk with the loved ones that you've chosen. Tell them what's important to you. Tell them what your wishes would be if you were so sick that you might die. Tell them what your wishes would be if the doctors are saying you need a breathing machine to survive. Tell them what your wishes would be if your heart was stopping. Would you want to go through such aggressive care for a small chance at surviving? And yes, you can ask me questions about that. And then document it. For your home, this needs to be documented here. Does that mean that a proper living will is a waste of time? It is not a waste of time, but the paramedics won't look at it. A proper living will can be very useful when you're making decisions. If you are too sick to speak for yourself and your family is making decisions on your behalf with a doctor in the hospital, but if it's in the very moment where we have to make a decision in the next 1 minute, we don't have time to look at a living will, which is why they want this, And it's also why when you go to the hospital, some of you have been in and out of the hospital for different reasons, right? If you get admitted, someone always comes to ask you what you would want. That's the wrong question, but they ask you what you would want if your heart were to stop. You've all been asked this question at some point, haven't you? Yeah. Do those conversations, are they well done? No, not usually. But if you know your own answers, it doesn't matter. You can then tell the doctors if you've thought through it yourself. You may still have questions for the doctor about what is or isn't possible at that time. This is a part of this talk where I don't want to talk too much. If you guys have questions about this, I'm very happy to try and help you. People have questions about what aggressive care is like. People have questions about, breathing machines, what life support is like, what it's all about, and what it means to go through CPR. If you want to hear about that, let's talk about it. What do people want to hear about? Go ahead.
We can talk about all that stuff.
Okay, so ask me questions. I want to give you guys the floor.
I want to know how I make that decision, like, let's, if I say don't resuscitate me, what does that mean?
Okay, let's get very specific. And we're talking in the setting of ILD, but I'm going to talk more generally in terms of it wouldn't matter what disease a person would have. If you have a chronic illness, and if you've become so sick from that chronic illness that your heart is stopping, that's the circumstance where we would be considering whether or not we would do what we call resuscitation. So that would mean that we would be pushing on your chest with our hands to beat your heart from the outside. They'd be putting the defibrillator pads on, and then seeing whether they could shock you, and then if your heart starts to beat again, and then also giving you different drugs to try to make your heart start beating again. And if it does, they would put a breathing tube down your throat, take you to the intensive care unit, and see whether or not you would ever wake up. Okay? That was a little graphic, but that's what it is. If you have a chronic illness and your heart ever stops, at best you have a 10 to 15% chance of ever doing anything meaningful again.
That is the question, isn't it? Will it restore you to any quality of life?
There's about a 10% chance if you have a serious illness already when that happens. We will get about 40% of people back. Okay? It will work in that we will restore it. We will get your heart to beat again 40 to 50% of the time. And half of the people we won't be able to get their heart back at all. But even those people where we get their heart back, we don't get their brain back. If a person is healthy and became and their heart stopped because of a new illness or because of a car accident or because of a sudden pneumonia or because of a blood clot, but their body is strong and they're healthy, the statistics are somewhat different. The chances that that person can make it through are different. But when a person has an advanced illness, if their heart stops, the chances that we can ever make them well are very small. That's a very specific question.
It's a very good answer, too. Thank you.
Yes.
What I'm saying is that if you die, our chances to make you not dead in a good way are very small if you have a serious illness already. If your lungs fail, it's a different question than if your heart stops. You will pass away if your lungs fail. If we're standing there trying to help you and we see that your lungs are failing, whether or not you can get better depends on what illness you have, and it depends on what exactly is happening with that illness. Interstitial fibrosis is one of the restrictive lung diseases, meaning that the lungs become very stiff. Now, I'm not a respirologist, but I can say this much. A person with advanced pulmonary fibrosis could survive an illness that requires a ventilator, but they often won't. And so then that depends. And you'd have to talk specifically with your own specialist about, at your stage of illness, is it possible to survive that or not? I'm not qualified to give you a statistic for someone who has ILD, but for very, very advanced ILD, people would never be able to come off a breathing machine if they're ever put on one, if the ILD is very, very advanced. Is there anything else that you would say about that, Debbie? I think that's a conversation that needs to happen with a respiratory specialist.
Yeah,
Right.
I agree. And it's going to change, obviously, every 6 months
Yep.
if your disease changes. So you have to keep that in mind.
Someone who's got relatively early ILD, who then gets a pneumonia on top of their ILD, might be able to survive a really bad pneumonia. A person who's got really bad ILD wouldn't be able to survive that really bad pneumonia. So it depends on where your illness is, depends on how strong your body is. So whether or not a breathing machine is something that could save your life depends on where your illness is. Whether or not you want that, I can talk about that with some authority. Imagine having, oh no, my finger's not big enough. Imagine having a tube that's the size of my thumb and is a foot long inside your throat, going down to about here. It's quite uncomfortable and it hurts a bit here. Okay, so that's intubation, and then we connect you to a ventilator. For all different types of illnesses, whether it's a heart illness or a pneumonia or something else, a blood clot, the overall average is that 75% of people survive that. It's different in ILD. ILD is worse, but it hurts to have the breathing tube in. Your mouth is dry, your mouth is open, your throat is sore, you might feel short of breath, you have tubes in you. Can they help you survive? Yeah. Is it unpleasant? Yeah. Is it worth it for you as an individual? Maybe. If I were to get that sick today, I would want that, because I would go through suffering for a chance to spend more time with my kids. So I know that, as well as anybody who's never experienced it can. I've never experienced any of that, but I would be willing to do that now at this time in my life. But you may not. That's of value. Are you willing to go through 1 or 2 weeks of suffering for a chance to survive a bad illness? I can't tell you. I can't tell you. Your respirologist can tell you what kind of chance you might have, but I can't tell you whether you should or shouldn't take that kind of treatment. Those are the two specific kind of big decisions. There's other types of support that a person can receive that don't cause so much suffering. Getting poked and prodded in the hospital, you're probably all a little bit familiar with that. If you're sick in a way that requires you to be in the hospital, then that's the sort of stuff that you have to go through. If that's how sick you are, you're hopefully able to discuss what you're willing to have and what you're willing to not have. We have 2 different types of high flow oxygen that people can get before they need a breathing machine. So we have regular oxygen, which can be by nasal prongs, or it can be by a mask, which can give a little bit more, right? And then we have a special device that can go up to 50 liters for people where a regular mask of oxygen isn't enough, but they need a lot of oxygen. So that's called Optiflow, and it's a machine with a piece of tubing that gets strapped on with a really tight elastic. You have 2 tubes that stick into your nose, and it's like you're driving with your head out the window at 50 miles an hour. But it really helps people, and people tolerate it pretty well.
Dr. Heibert,
Yeah.
is there only one of those in Manitoba?
Oh, no, they have them at all the hospitals. Yeah, and we even have one on the palliative care unit for people who might need it. Yeah. So, this machine, there's got to be a dozen in every hospital. Like it's available. So if somebody's in respiratory trouble and they need more oxygen, we have a high flow oxygen device that a person can receive. And that's a reasonable thing to try if somebody wants a chance to survive an illness. Above, yeah.
Well, MAID.
I'll get there. Let me finish this part and then we'll talk about it. I won't be able to tell you everything. There's another type of breathing machine I want to tell you about, and then I'll answer the questions. There's another type of breathing machine if the optiflow isn't enough, and that's called BiPAP. Are any of you familiar with BiPAP or CPAP? Are any of you wearing CPAP at night? BiPAP is similar. CPAP has the tight mask, and it pushes all the time, right? And it goes brrrr all night long. At least the one at home does. BiPAP pushes. Every time you take a breath, it pushes to give you more. So it's got a computer and a sensor. And so every time you take a breath, it pushes more in. It's a little bit uncomfortable, but it's a lot less uncomfortable than a breathing machine, a breathing tube. And so the optiflow and the BiPAP are two ways that we can try to help people without having to put them on a ventilator. And they're very reasonable ways to try and help a person. Optiflow can get done in the regular part of the hospital. BiPAP, if it's for an emergency, needs to be in the emergency room or in an intensive care. Okay, but they can help a person through. Okay, so I wanted you to know about that. Okay, and then we'll talk about MAID, but go ahead.
Those two things that you just mentioned. So once you're on that, do you have to be on it forever?
No, these are treatments to get through a rough patch. These are just like if you get sick, you might need antibiotics for 10 days. You are sick, you might need BiPAP for 2 days. Okay? You are sick, you might need optiflow for a few days. You might live normally on 2 liters of oxygen, but when you get sicker, you need to go on 7 liters. It's like that. And then you hopefully get better again. Someone brought up MAID. What question would you like to, or what part of that? That's a big topic. So a question about an experience of having a friend with ALS who, when their disease progressed, eventually chose to receive medical aid in dying. So MAID is the term, M-A-I-D, medical aid in dying. I will say out loud on the record that I do not like the term, because what does it mean to provide aid when someone is dying? Palliative care. So the term itself should be something. It should be called something else, but we're talking about helping a person die faster who no longer wants to live. A medically hastened dying. That is legal in Canada if a person has an illness that will cause them to die. It is also legal in Canada now if a person has an incurable illness that causes them to suffer and their suffering by the way they feel cannot be relieved. So even for a person who isn't expected to die very quickly, medical aid in dying is a legal option now. For the second scenario where someone isn't dying of their illness, the process is a little bit more complicated and takes longer. If someone has an illness that's killing them, then having medical aid in dying is a more straightforward process. I think in order to make a decision about medical aid in dying, that it's worthwhile to know a few things before you make that kind of decision. And it's worthwhile for me as a palliative care doctor to have more information about that person so that I can try and help them. Something that very often happens is that we will meet someone as palliative care doctors after they've already expressed the desire to die from their illness and not before that. And that's unfortunate. And part of it is because we maybe aren't as available as we wish we would be. If somebody already feels like their life is not worth living, it can be quite difficult for us to do anything about that feeling. If a person feels that their life is no longer worth living, I'm a doctor. What do you think I would like to do? I'd like to find out why the person is, what is causing the person to suffer. And I would like to find out, what is causing the person to feel that their life is no longer worth living. Because sometimes there's something I can do about that. And sometimes we can make life better for that person again. That doesn't mean that they don't have the choice, but it means that sometimes we can help them with the issue or the issues. Medical aid in dying is an option for people who are suffering in ways that are not acceptable to them, people who have an illness that's causing them to die. And so that is absolutely an option. It's provided by a team that's separate from the palliative care team. It's frequent that people are getting palliative care, and we're doing everything that we can to support the person. And then while we're doing that, the person chooses to have medical aid in dying, and we just keep trying to help the person as much as we can, and we support them in any way we can, whether they choose to have it or whether they do not choose to have it. I think it's important to know something, though. We know that if you choose to have medical aid in dying, you know that when that happens, you'll be dead, right? But do people know what it would be like or what it might be like to have natural dying? In my opinion, now you can disagree with me and that's okay. In my opinion, it would be good for a person who's making such a big decision to know what either choice would be like for them. Does that seem fair, sir? Yeah, and I don't say that with any intent to change someone's mind, just to inform them of what the two choices are.
So, Dr. Heibert, like, I know if we all say the thought of dying is scary, but if palliation and in your profession is done right, death doesn't have to be scary because your team is going to be with us through each step of the way and with each process that death involves.
Death does not have to be scary. I cannot say that a person who's dying won't suffer because we don't have good enough medicines, we don't have good enough treatments to entirely get rid of all suffering. And we're not good enough at our jobs to be able to say that no one will ever suffer. So there are people whose suffering exists in such a way that medical aid is what they really choose to have. And that is their right to do. They can do that if their quality of life is such that they can't. What I would ask is for a chance to help them relieve their suffering for as long as they're living, even right till the day that they choose to have that procedure and have their lives end. So what happens very often is that we continue to provide palliative care right up until the day that a person has medical aid in dying. So an important comment asking at what stage is having medical aid in dying right for a particular person. Most people don't ever choose to have medical aid in dying. It's a percentage of people who want to hear about it and a smaller percentage who want to have it in the end. And there's no particular time. So I actually don't have an answer to that question. I don't know that, other than to say that that is a value judgment, and that I do not have the right to make a value judgment about someone else.
I could rephrase it.
Yeah.
So what stage of the disease can I, if I say I'm ready, will I be legally able to?
The law doesn't specifically say how much time, but the provinces have been applying practical guidelines. And my observation is that they're looking at someone who has a clearly shortened life expectancy for the first criteria for MAID.
Like a year?
Like 6 months. I don't know. I'm not a medical aid in dying provider. But the law states that a person's death needs to be reasonably foreseeable. And the provinces have all interpreted that in their own way. But that's for what's called track 1 MAID. Track 2 MAID does not require someone to have an illness that's killing them. That process takes longer. That process takes several months. For that process, for that decision, a person doesn't need to have a certain life expectancy. For people who are dying of an illness like a lung disease, it's usually happening within the last 6 months of life expectancy, but I don't know what provincial policy, whether there's a policy or not, I don't know the answer to that question.
I can make another one up.
When you come to the hospital and you're sick, if you have an ERIC kit, the paramedics will take it along with you. Once you get to the hospital and you're already in the hospital, your family should take that back home again for you.
Take it back home.
Yeah, after. When you're in the emergency room, one of the emergency room doctors is going to talk to you or is going to talk to your family, or one of the internal medicine doctors or one of the surgeons or whoever it might be. And that conversation might be better or it might be worse. Hard to know. But after you get to hospital, they will create a form that's very much the same as this that will apply while you're in the hospital for that hospital stay. So every time someone comes into the hospital, we try to ask the person what their wishes would be, whether they want to have resuscitative care, which is if their heart stops, that we try to restart their heart with chest compressions, electricity, and drugs, or whether they want medical care, which could include a breathing machine, by the way. Medical care meaning all of the drugs and all of the treatments to try to keep a person alive and help a person get better, or whether the person wants to have comfort care, which would be treatments only for the purposes of being comfortable, not for the purposes of living longer. Those are the 3 categories. That's much too simple, but those are the categories, and then we can add extra detail as it's specific. But when you come to the emergency room, someone will be asking you those questions, or your family those questions, if you're staying in the hospital.
Okay. And if you had that,
Yes?
you can also use that.
Yeah. So people can answer these questions in different ways. Let's imagine a person with a cancer. Let's imagine that this person has been doing okay with getting cancer treatments, but they're a little bit weak and they've already been through some serious illnesses where they've been in the intensive care unit. So that person wants to get better if they get sick again, but they've been through an intensive care unit stay and they no longer want to go through that kind of a hard experience again in order to stay alive. They would like to get all the medicines that they could get to live. They would like to get medical treatment with intravenous antibiotics, with fluids. They're willing to have another CAT scan. That's medical care. But they want the team to make sure that they're comfortable. And if they're not making it through, they want the team to focus on comfort. So that person's form then should say that they want medical care with a focus on comfort. Just as an example. So they would be designated as ACP M, meaning that they want medical care. So they're in that M category. But then you would also want to indicate on that form, when I'm the doctor who writes it all out for them, that they want comfort together with the medical care. When someone wants to have MAID, they want to take an act to cause themselves to die actively. And that might be what's best for that person, given everything about how their lives are, what they're experiencing, that their quality of life has been lost, and we don't have a way to give them quality of life back. So that is medical aid in dying is an act that directly causes the person to die. When we withhold treatments or we stop giving treatments, what we're doing is allowing the illness to happen. We're not causing the illness, but we're allowing the illness to happen.
Run its course.
We're allowing, yes, thank you. Those are better words. Someone said we're allowing the illness to run its course. And that's what we're doing when we stop intervening. And to me, and to most people who are in the world of ethics, they would say that there's a difference between an act that causes dying and a decision to allow an illness to take over. I don't know if I've answered your question,
No, that's good.
but that's my answer.
And then there's no conflict with the Heibert.
There's no conflict. And a person who wants to have MAID, it doesn't matter what I think about it. The person has the right to have that if that's how they really feel. It is true that many people who want to have MAID will say that out of a sense of hopelessness. And I would wish, as a care provider, to try to address that hopelessness in some way, if I can. Yes. Well, either way, I would hope that the person's value and the person's value is always maintained. Every person has value. The notion that we're only valuable when we can do something for someone else, I do not agree with that idea. I agree that we all have value, even when we need help. When a baby is born, that baby needs help with absolutely everything. Is that shameful? No. It's often messy, but it's not shameful. Unless we die very suddenly of a very sudden illness or an accident, the only people who will not need help at the end of their lives or later in their lives are those people who suddenly die, which is a very small percentage of us. All the rest of us will need help in our lives. And most of us need help in our lives for a long time. There's no shame in needing that help. There's no loss of value in needing that help. And there should be no loss of dignity in needing that help. Unfortunately, our society doesn't always see things that way. So opioids will reduce the stress of breathing. And when you reduce the stress of breathing, you reduce the release of adrenaline, for example, in the body, and then the body doesn't demand as much. Am I making sense to you? And so then that allows a person to relax. But it does not fix a person's breathing. With cancer, we're probably reasonably accurate, depending on the type of cancer. With virtually every other disease, there's a lot of variability. There's no specific indicators, with all respect to Dr. Homick and with all respect to Dr. Colburn and to Dr. Porhonek and to Dr. Gruchalski and to all of these different excellent respiratory doctors, there are no specific indicators that they can turn to that will tell them reliably exactly how long a person has to live. But what I can tell you is that if a person is having to come for medical attention more and more often, if their symptoms are getting worse noticeably over a period of every month, it's worse than it was the month before, despite the fact that the doctors and nurses are doing everything right and giving all of the right treatments. And if the person is having to come back and forth from the emergency department or from the hospital with increasing frequency, and the person is able to do less, and this is noticeable, that person probably has less than 6 months to live. But there is no reliable way. Yeah.
I guess, do we ever think of asking for ourselves to be enrolled in a palliative program? Like, I never thought of that till we were...
Yeah, you could.
Yeah.
Yeah, you could. Yeah. Or to be seen by a palliative care doctor. You absolutely have that right.
Yeah.
Yeah.
And I know the nice thing too with the palliative care program is a lot of the services are covered then. Your drugs are covered, the medical supplies are usually all covered.
One of the difficulties so we're victims of success. Because we pay for people's medications and because we provide certain services, we can only do that for a certain number of people at a time. And because of that, the way that the bosses, whoever they are, have decided to do that is by picking a life expectancy. We're trying to find better ways to decide who needs this care, because there should be a better way. It should be based on who needs it more so than how much time. Because you might have 2 years to live, but you really, really need that help.
So you were talking that there's maybe a change coming to Manitoba.
Well, we're trying to do better. We're trying to become more flexible, but the policies are still the policies.
So is there anything as an individual or as a group that we can help you with in advocacy?
I feel very comfortable to say is that I think it really helps us for advocacy groups to advocate for more palliative care services in our province. We do not have enough palliative care supports in our province to provide to everyone who needs it.
Awesome.
We do not.
I mean, awesome that we could maybe
You can say
formulate
that.
a letter that some of
Yeah.
us or all of us could sign and send to the Minister of Health.
And people with pulmonary diseases get less palliative care than people with cancer.
Wow.
And I say that wishing it was different. If we had more palliative care supports in Manitoba, people would not need to go to the hospital as often. People would be able to go home from the hospital sooner. If people had access to seeing palliative care doctors or palliative care nurse specialists more easily, we'd be able to help you make better decisions about which tests and treatments are useful for you and which tests and treatments are not useful for you. And statistics from the United States show that reduces healthcare costs because people don't get that last CAT scan that they don't need, for example. And they make the decision more clearly about what kind of care that they want the next time that they have a respiratory exacerbation. And so part of my statement about wishing for more palliative care is that having more palliative care supports in our system would reduce the overall burden upon our hospitals. And people would be getting care that fits their wishes better, which is important for people. And we don't talk about it that much. It's cheaper. But that's not the reason. That's not the reason to talk about it.
Just a real quick question.
Yeah.
Certificate of expected death at home. When does that take place?
If somebody is declining with their illness, and generally speaking, if they're receiving palliative care and they don't intend to ever return to the hospital, and they intend to let themselves pass away at home with help, then there needs to be documentation so that it doesn't become a legal problem for their family or whoever's there. So if a person chooses to receive end-of-life care at home, which they can do, about 30% of people who get palliative care in Winnipeg will die in their home. Okay? We want to do better than that, but that's the number right now. During 2021 and 2022, we were up to about 40 to 45% because no one wanted to be in the hospital. And people were also working from home so they could help their family members. So if somebody is dying at home, we prepare a letter that we send to the medical examiner's office and is sent to the funeral home of that person's choice. The person has to choose a funeral home because the medical examiner is stubborn about that. They need to know what's going to be done. The letter says that we know that this person is very ill. We know that this person is expected to pass away at home. And I, as their physician, certify that this is a death that's expected and that I will fill out the registration of death form. That's simple. As palliative care providers, we fill this letter out for all of the patients that we're looking after. And then when that person passes away at home, the only thing that the family has to do is call us to let us know. Well, they don't have to, but we ask them to call us and then call the funeral home when the time comes. Without that letter, the police have to come to the home. That's scary and stressful. If a person is receiving end of life care at home, and we're planning for it, and we've done this documentation, when the person passes away, all that needs to happen is a call to the funeral home to ask them to come. That's it. Yeah, and then it's not stressful. And then the family can focus on what they need to focus on, which is supporting each other. Well, if a person, so the question is about what about a person who's single and doesn't have close family who's with them, who, let's say, has pulmonary fibrosis that's gradually progressing. When it's time for end-of-life care, and if that person's wanting to stay home as long as possible, the palliative care team will try to support that person as much as they can. We use the home care services as up to the maximum amounts that are allowed. We provide equipment for that person. That person, we'd probably recommend that they get a lifeline, or the, what is it called? The lifeline button. And we have nurses visit a person like that fairly often.
I see.
But inevitably there will be a time when that person can't get out of bed anymore, or that person's starting to fall down, or that person might be starting to get confused or just getting sick repeatedly and needing help with care. So people who are single will almost always die in hospital, unless they die alone, unexpectedly. So people who are single will almost always come into hospital when they pass away, because we don't have another way. The exception would be someone who's wealthy enough and wants to hire 24-hour care, which there are a small number of people who choose to do that, who can. Okay, I think we're getting to a point where I have to kind of move on with my day. I hope that this has been a helpful conversation. And thank you for all the questions. I think I even questions are being asked in ways that I haven't thought of before. So it's good to hear new perspectives on things.
Thank you so much, Dr. Heibert, for being with us again.